Welcome to our today's live broadcast, Cure Chronic Lymphocytic Leukemia Educated Patient Webinar. My name is Andre Gouin. I'm the chair of John Thorough Cancer Center and the physician-in-chief for oncology for Hackensack Meridian Health. And I'll be your moderator today's event. We are pleased to bring you this webcast presented by Cure and sponsored by Janssen and Pharmacyclic. Just a few housekeeping notes for our audience. We have a few very important announcements. You will be receiving a survey via email tomorrow, and as a token and a thank you for watching the full webinar and completing the survey, you will be entered to win one of three gift cards valued for $100, $200, and $300. So please wait until the end of the presentation so that you can apply. This webcast is designed to be interactive. This is very important. And we know that you have a lot of questions. We encourage you to ask those questions during the event. You can submit the question by typing them in the QA box on your screen, which can be found on the right of the video. And these questions will appear on our screen, and we will answer them during the program. If you have any technical problem viewing or hearing this presentation, please click on the question mark help widget in the dock at the bottom of your presentation window. We are very pleased today to be joined by Susan O'Brien, a great friend of mine, professor and associate director of clinical science at the Chow Family Comprehensive Cancer Center at the University of Irvine, California. Susan is one of the most well-known leukemia physicians, particularly in CLL, so we'll be very excited to hear her perspective as well. We also have Dr. Lori Leslie, one of my colleagues and friend as well, who leads the indolent lymphoma program and CLL in the lymphoma division at John Thorough Cancer Center. Lori has also a lot of interest and passion for clinical trials in CLL. And finally, Dr. Andrew Ip, who is an hematology oncology attending with a focus on lymphoma and myeloma, will also spend quite a bit of his time on outcome and value research in a new outcome division at John Thorough Cancer Center in Hackensack, New Jersey. And we'll hear Andrew also giving us his perspective of registry in the context of COVID, as we obviously cannot not talk a bit about COVID in the context of cancer nowadays. Thank you for joining us today. So without further ado, I want to again thank our faculty panel to have joined us. And then I will go straight to the subject. I mentioned COVID, and I think this is a really important aspect to all our audience and to cancer patients and the public as well, is how we manage cancer and how we have done this in the context of COVID. How did we adjust and how things are finally getting better? And what is the impact on the treatment that we have and what we have done to create basically a safe environment? So Susan, if you don't mind to give us your perspective at your center, and then we'll share our perspective at John Thorough Cancer Center.
Yeah, I mean, I'm sure it's very different here than there because we know what happened to New Jersey and New York. Of course, there was a lot of social distancing here. And ironically, or maybe not surprisingly, now that we're starting to open up, I think the cases are actually going up, whereas I don't think they were before. So it's kind of ironic that retrospectively, at least in California, we were probably safer bringing patients in than we will be going forward. I think certainly all of us have gone to a certain number of video visits. That tends to work relatively well in CLL. Obviously in acute leukemia, which I also treat, those people have to come in to get blood, platelets, et cetera. So we haven't gone in that direction there so much as in CLL, and it works particularly well for watch and wait patients. I think my own guess is that when this is all, I don't know if I should say over, but better or dies down, I think probably video visits to some extent are here to stay. So I think that's one potentially positive change that's going to come out of this.
Thank you. You guys studied the social distancing pretty early on, right?
Exactly. That's why I think that's why we were not seeing that many cases, but now everything is opening back up, as of course it inevitably will. And now we're actually starting to see a rise in cases. It's not shooting up, but it's definitely going up, not down.
Lori, you want to share a bit on how we adjusted in one of the epicenters on the East Coast?
Yes, so we have had a different experience, it sounds like, than Susan on the West Coast, in that we had a lot of cases early on. I think at the max, at least at Hackensack, we had somewhere around 600 patients admitted with COVID. And basically, on the inpatient side, had to turn most of the hospital into COVID units and move our oncology patients to different areas to protect them and make, develop a rapid COVID test here at Hackensack, and really was very impressed with, Andre, your efforts and the efforts of HMH, obviously, to change how we see and protect patients very quickly. So screening procedures for patients coming to the outpatient setting with checking everyone's temperature, screening contacts, to make sure that we were trying to isolate patients with weakened immune system. Of course, social distancing, masking, universal gloving, all of that started very early on. And it's been wonderful to see how quickly things have improved. So at the peak, I think we had about, again, 600 cases admitted. That's now down to maybe 20, 30, something like that, who have mostly been in the hospital a long time. And looking at all the people who are on the front lines, we've seen that, the rate of conversion of people who did kind of catch COVID as part of their care for these very critically ill patients was low. So from our experience, we know the PPE works. We know the screening, the temperature checks, the hand washing, the sanitizing, the protocols we've been following. I've been very reassured moving forward that the way we're seeing patients right now, we can share with maybe places that haven't had such a big experience with COVID about how to progress as things open up and keep cancer care safe for our patients, no matter how things pan out over the next few months.
Are you allowing visitors to the inpatients? Can they have a caregiver there, a significant other with them, or no?
So there's no inpatient visitors allowed, except for certain circumstances. If a patient were in a, end of COVID situation, end of life situation, for whatever the reason may be, then we do allow visitors under those circumstances. But for routine admissions, we do a lot of video calls with family members on rounds, trying to make sure patients have access to some sort of device to do that. And at the cancer center too, we weren't allowing visitors to come in with patients for their visits or treatments. Now we've opened up a little bit and we'll allow a family member in the visit room with the doctor to talk about the plan, but we're really trying to not have visitors in the infusion room, for example, to minimize. And those visitors get their temperature checked and mask placed and hands washed the minute they come to the cancer center as well.
This is a really good point, and I just want to add that really well said, that one of the main concerns of patients in general is to go to a healthcare facility or the doctor or cancer center. And as you mentioned, we have now tested 9,000 employees from our network, and have found that a very, very small fraction of them have actually been exposed to the virus and have developed antibodies. And therefore, that's what is expected. And what we expected is that the virus is caught in the community, not in the hospital, because of the PPE. So this is very important to reassure our patients in that setting. Andrew, I would like you to give a little bit of your experience. We're not going to spend too much time on the COVID therapy tonight, but you've been very involved firsthand with the outcome division and trying to understand on how to manage these COVID patients. And definitely that has some implication, because cancer patients can be sometimes have a more severe form in a COVID situation, particularly if they're on chemotherapy. So you want to summarize a bit your experience?
Yeah, absolutely, Andre. Thanks. I think the first thing I would say is we've basically collected a database of about 5,000 patients. 500 had cancer and about 40 had some form of lymphoma. And what we found after doing adjusted analyses is that it's not necessarily the presence of cancer that makes a patient higher risk or some comorbidity, but it's really their age. So really it's the risk group of age over 65 or 75 or even higher that really played the biggest factor in severe COVID and worse outcomes, and not necessarily the presence of lymphoma or cancer. And in terms of treatments, there's been a lot of press as well lately, but there's really been no magic bullet per se, but there is certainly a lot of hope and promise in terms of convalescent plasma, which is basically recovered patients plasma that's donated and has high antibodies, and then is then given to patients, and there seems to be promise in that. There's also other therapies that are in investigation still, including an antiviral drug called remdesivir that seems to be promising, and then some anti-inflammatory drugs like steroids or tocilizumab that our database is also showing to have some benefit as well.
I think this is a really important point that you make in terms of treatment, and we have we obviously have the convalescent serum as part of the expanded access, but we also had this concept of convalescent plasma, which is, as Andrew mentioned, selecting the patient with a high immune response and a high level of antibody. And this is the work of Dr. Michel Donato, who led this work and actually was on 60 Minutes 2 weeks ago about this work, and Dr. David Perlin. And they have done remarkable work. And I had actually a patient recently who has lymphoma on maintenance therapy, doing well, but had COVID in a different hospital and was still febrile, not very sick, but febrile 4-6 weeks into his diagnosis of COVID, and had still virus positive in a swab and had no antibodies when he was tested twice. So we admitted him briefly, gave him some plasma, and this was over 2 weeks ago, and then he has been febrile, doing really well. So this is an important example. As for cancer patient, it will give us an alternative, particularly patient with lymphoma that can be sometimes lymphopenic, low lymphocyte count, either from the lymphoma or the therapy sometimes, and sometimes neutropenia, low neutrophil post-chemotherapy. They can have more infection complication. So if we can accompany them with this plasma, we can actually mitigate the complication. And I think this is very reassuring to be able to do that for the high-risk patient, where, as you said, Andrew, that's where the mortality is. So we covered a little bit on the COVID, and then I think we'll talk a bit more on how COVID maybe changed the treatment of CLL. I think without further ado, I want to jump into what's the excitement in the field in CLL is the ultimate example on how a disease has changed from many years of same therapy, and then the FCR that was established, Adam Jensen with Susan, and then became the reference, and now we have all these novel options, novel therapy, particularly overall agent, that have revolutionized the landscape. So I think that we right away have some questions that we can answer. Is that what is sort of a general question? What is the best treatment for someone who needs treatment to start treatment with CLL? How do you decide, and what test do you do to try to decide? Susan.
So I'm not sure there is a best treatment. There are a number of good treatments. Do I still consider chemotherapy anymore at all? Really only in a small subset of patients, namely those that are fit, so generally younger and mutated, and that would be FCR. And the reason for that is, the data showing a plateau on the progression-free survival curve, sometimes going out 16 years based on the MD Anderson data. And I actually think there is a cure fraction. But if you take fit/younger patients who are mutated, it's a very small subset of the total population. So then it was pretty straightforward. If you weren't going to give them chemo, you could give them a small molecule. It's really, really important to know their 17p status if you are thinking about chemo, right? Because you definitely do not want to give chemo to a patient with a 17p deletion or a p53 mutation, because they will not respond. So it's very clear in that population, you don't want to go anywhere near. In that population, we have several good options now. We have ibrutinib, which has the longest track record. We have acalabrutinib, which also looks very promising, which can be used plus or minus obinutuzumab. And then, of course, we have venetoclax obinutuzumab, which is a time-limited therapy where the patient only is treated for 12 months and then stops. So generally, I will talk about the various side effect profiles. I'll talk about the indefinite versus finite amount of therapy, and also the track record. That acalabrutinib looks great, but we don't have 5-year frontline follow-up with that drug. And so sometimes that's important to the patient, knowing that there's 5-year data versus, 1-year data. So I kind of touch on all of those points. Obviously, those discussions about treatment have gotten longer and longer recently with all of these novel agents, which is a good thing. But it certainly gives you a lot of options, all of which I think are really good.
So, Lori,
actually, can I jump in, Andre?
Oh, yeah, sure, go ahead.
Yeah, as being the most junior person here and trying to still understand the data, Susan, if you had like a very young patient, 50 or so years old, which is a scenario I encountered recently, would you favor more the limited duration, or do you go more based on the track record and other data, assuming they're deletion 17 and so forth?
So if in a younger patient, and I think it's a good point, in older patients, I think continuous therapy sounds a little less intimidating, because if you think about older patients, they have comorbidities and they're often on continuous lifelong therapy, right? Antihypertensives, statins, et cetera. I don't necessarily think it's as a big deal. Whereas I think for a younger fit patient, where you tell them, you know, you're going to be on this for years, I don't know exactly how long, but years, I think it's much more intimidating to them. So I will admit that in a younger patient, and again, I would also consider chemo if they're fit mutated, but let's say they're unmutated, I would much more lean towards probably a venetoclax-based regimen, so that they're not going to be continuously on therapy. But in the end, I try and give them the option to make the decision.
And I think you guys raised a great point that this how to do time-limited therapy is something that's, for our patients listening, a very active field of CLL research, because it's really hard to challenge these things. And even if you plan a time-limited approach, maybe the way things pan out, you might actually end up continuing therapy, or vice versa. If you plan a indefinite therapy, maybe there's a clinical trial or some other consolidative approach that becomes an option that will kind of transform into more of a time-limited therapy. So I agree with you, Susan, in that it's really challenging kind of to have these conversations, because the field is evolving so quickly that I've had patients, I start their treatment within the past 6 months, and then within 6 months, practice-changing data comes out, and it would have changed potentially what they picked based on the current knowledge. So it's hard without a crystal ball to know what to do, but I agree with you. It's very reassuring. We have so many good options in the frontline and relapse setting.
True.
It's a good one to have the question, two questions that are around the same thing, that now that you have ibrutinib and acalabrutinib both usable in that setting, what is your discussion to try, and your criteria to try to pick one or the other, and advantage and disadvantages?
So again, the two things I would focus on, since they're both continuous therapy, you don't have to deal, if you're just focusing on those drugs, with the finite versus indefinite. I talk about the difference in the safety profile. Obviously, there's more headache with acalabrutinib, more diarrhea with ibrutinib, but most of those side effects are time limited, and patients develop tachyphylaxis. There does appear to be more cardiovascular toxicity with ibrutinib in terms of atrial fibrillation and hypertension. But, if you look at the data for ibrutinib, we're about, depending on the trial, maybe in general, 12% of people develop atrial fibrillation or the irregular heartbeat. That means 88% of people don't. So we're talking, differences here between the two drugs, although the majority of people on either drug will not get that side effect. So it depends how much you pay attention to those small differences. And then the other thing I discuss is the track record part. I think the early data with acalabrutinib or Calquence looks great. But again, do we have 5-year follow-up? No, we do have 5-year follow-up with ibrutinib, that 70% of people who started it as their initial therapy were still responding 5 years later. That's pretty impressive data, I think. Does that mean we won't see that, or even better with acalabrutinib? No, it doesn't. It just means that we don't have 5-year data. So if that's really compelling to somebody, wow, if I start this drug 5 years from now, 70% likelihood I'm going to be in remission, that they might then opt for the ibrutinib. So again, it's kind of seeing what to your patient, to that individual patient, they weigh more heavily in their decision making. Is it side effects? Is it track record of the drug? Is it not having stopping therapy? Initially it sounds nice to stop therapy, but I learned in the days when I treated a lot of CML and we started doing the trials where we took people off if they were in molecular remission, is some people don't want to come off. They would look at you and say, what are you talking about? I'm doing great. I'm not having any problems with this drug. I don't want to stop my drug. So you can have very disparate, thoughts and an individual patient about whether stopping therapy sounds attractive or whether actually sounds very unattractive. So again, I think what's important to the patient always comes into the discussion. If we had one drug that was clearly better than all the rest, well, I think the discussions would be different. But here we have, as we've just said a couple of times, several great options. And so that's where I think it comes down to a little bit more to the patient decision, since all of these options are good.
So before we change, we'll go a little bit further into the duration treatment, MRD, and all that. We're going to talk a little bit more about the time when to start treatment on the CLL. We have this novel therapy, so one of the questions that comes, before we had mostly chemotherapy, so we sort of waited until it was worth it and all that, and then does it change the paradigm now that we have novel therapy? And what are the criteria? Well, particularly, were two questions regarding someone who is diagnosed stage 0, two of our audience, and then a rising white count, slowly rising over 6 months. The physician oncologist says to not worry, but obviously the patient is worried. So if you, Susan, if you can comment a bit about the impact of this novel therapy to maybe decide to treat earlier, question mark, and then what are the criteria to really start on treatment and have they changed?
So generally, if the CLL is not causing a problem, we watch and wait. Though similar to stopping therapy for some patients, that can cause a lot of anxiety because patients will say, oh, I have this cancer, we know it's there, we know what it is, why aren't we treating it? Some patients that have good features, like that mutation status we've mentioned, mutated and no genetic or chromosome changes that suggest you're going to have a more aggressive CLL, some patients can go decades even and never need treatment. So starting treatment early would potentially give side effects, potential side effects of the drug, or open the door to develop a more aggressive CLL or resistance because you've treated when you maybe could have just observed. I like to compare it to infections. So if you have, an infection and you start antibiotics and you don't continue taking it or whatever changes in that bacteria, you can develop a superbug, that resistance. That can happen with CLL too. So the sooner you start treatment, the sooner you start that clock to develop potential treatment. So since patients get potential resistance, since patients can go a long time on observation, we tend to look for things that would give us an idea a patient's going to become symptomatic even before it happens, to know when to jump in with treatment. And that was what Andre was referring to about that doubling lymphocyte count or white count. When we look at your CBC, we see the WBC or the white count, and a portion of those are the lymphocytes, the absolute lymphocyte count. So I know a lot of patients probably follow their electronic medical record trends of their lymphocyte count, and that's what we're following too. And what we look for is a doubling in a 6-month period or an increase by 50% in a 3-month period. And that tells us something may be changing in the CLL. It's getting more aggressive, and we may need to jump in with treatment soon. That doesn't mean that a patient comes in and has a doubling of their lymphocyte count and they start treatment that day. Typically, if they've been followed every 6 months, we'll see them a little earlier, maybe in 3 months or maybe in 1 more month, to kind of help get a better picture of how the lymphocyte count is changing, mostly because other things can affect the lymphocyte count. If you have a cough or cold, the lymphocyte count can also go up and then come back down. So you want to make sure it's a constant trend. You can also get low blood counts, like the hemoglobin going down, anemia, or low platelets. That can be from the CLL, or that can be from the CLL activating the immune system and destroying the platelets and red cells. So those are different scenarios that may or may not require treatment. And then also we look for the rate, if you have any enlarged lymph nodes or enlarged spleen, we look at the rate of which change, or if that's causing symptoms. That would be another indication to potentially start treatment. I'd like to hear from the rest of you too, but in my practice, I haven't changed those guidelines with novel therapies versus chemotherapy, chemoimmunotherapy. I think I still wait for the classical, symptom or ALC doubling time guidelines. But the genetic and molecular features of the CLL do sometimes change how frequently I observe someone. Someone who's, very low risk molecularly, I maybe observe a little less frequently versus someone that has that abnormal 17p or p53, which is kind of your genetic spell check. If that's abnormal, it makes the cells more unstable and maybe a higher risk for them taking off more quickly. Those patients I tend to observe a little more frequently or a little more closely.
Yeah,
Andrew,
I would agree.
yeah, go ahead, Susan. Sorry, please.
I was just going to say, I would agree that where the prognostic factors guide me is not into starting early therapy, but really the follow-up. As you said, Lori, for a high-risk patient who I think is likely to progress over the next year, I'm going to see them more frequently than a low-risk patient who has all good prognostic features and where I think that they'll probably take years and years to progress. So it doesn't make me start treatment sooner. And I'd also point out that if you were thinking of using a BTK inhibitor, namely ibrutinib or acalabrutinib, if anything, the fact that it's continuous therapy really would make me shy away from starting early, because once I start it, now I've committed that patient to years of the treatment. So rather than making me go more in the direction of, oh, well, this is so well tolerated, maybe I don't have to do watch and wait. No, it would not make me go in that direction. So I would still do watch and wait, just like when our only option was chemo.
Andrew, I'd like you to comment a bit on the routine workup of the CLL. It's obviously to do some blood work, and then we do more and more, because now people hear that they have access to their genome, or they can do sequencing, and then what kind of molecular testing they should be receiving on a routine basis that could help them in their treatment. We know the FISH is a typical part of the panel, but can you comment a bit more on how you manage the molecular workup of the CLL? You're muted. We can't hear you.
Okay, sorry. Before I answer the molecular workup, I wanted to ask Lori and Susan in the regard symptom of fatigue, which I feel like is, for patients especially, it's hard for them to really explain it or not, and also for the physicians and us to really say, is this really symptomatic CLL or not? It may not be by strict criteria, but I know at least where I trained that sometimes that came into play, especially if it's something like their lymphocyte that's maybe more or less doubling 6 to 9 months or something, like in that scenario, and how you guys look at fatigue as potentially a reason to start treatment or not.
So you're exactly right. That is a really complicated scenario, because we know that there's many reasons people can be fatigued that might have nothing to do with the underlying disease. And so that would be the only indication for treatment. So, their lymph nodes are not big, their counts are pretty good. I'm really, really, really conservative about starting treatment and try and look for other causes. I mean, simple things like thyroid functions, right, that we can look at. And then one of the things that helps guide me is, it's such a subjective symptom. So what I try and do to get at how dysfunctional it's making the patient is I ask them for their age range, what can they do vis-a-vis what somebody else who's, say, 70, their friends can do. And it's really funny the answers you'll get, because sometimes people will say I'm fatigued and they'll say, oh, I do way more than them. Right? So I try and get engaged for, are they just being super critical of themselves that they think they should be doing more, or do they really have a lot of fatigue? And then the other thing I think sometimes helps is if they're really frequently complaining about fatigue such that, it seems like it's impacting their life and it's really unpleasant, I will say to the patient, okay, well, if I don't have any other reason for treatment, do you want to be treated for this fatigue? And again, you get very different answers. Some people are like, God, no, I don't want to be treated. I'm just letting you know that I have fatigue, but I don't want to get treated for it. And then other people, I occasionally have had somebody say, yes, it's just awful. I can't function. So I think sometimes asking the patient, is this something you think is worth treating for, can then give you an answer about, well, is this worth treating for or not?
And I agree with Susan. Maybe because I trained at MD Anderson under Susan, I seem to agree with her on everything among the other CLL experts there. But I think even when I was in fellowship, there was a study looking at this, because CLL can, I was in Michael Keating's clinic, I think, and he had a few patients on it, which was looking at a JAK inhibitor for patients with fatigue as a side effect of their CLL, because CLL makes so many proteins and inflammatory cytokines that can be the only symptom. I do struggle, and I haven't yet started a patient specifically for fatigue alone, but I agree that helping ask, like, what did you do a year ago? What did you do 6 months ago? What are you doing now that you didn't do before? Do you take naps? Like those type of things are helpful. I'll have patients that used to walk a whole golf course and now, a month or 2 or 3 later, they're, using the cart or not golfing at all. That's a common example I come across, and they might not have realized how dramatic their life is because it came on relatively gradually, but they do report it or complain about it.
And then regarding to routine workup, and I saw there's a question about just monitoring the parts of the CDC or blood, and really we look at hemoglobin less than 10 or platelets less than 100, as well as the lymphocytes doubling, as Lori and Susan mentioned. But molecular workup, there is certain prognostic indexes, the CLL, IPI comes to mind, and but really the things that we really focus on are deletion 17p, as a worse prognostic factor, and then things that are more favorable would be trisomy 12 or mutated IGHV, as some common prognostic markers. But certainly at our practice, we're also using some next generation sequencing from peripheral blood samples to also get more data from their molecular profile to try to guide prognostic and treatment as well. So.
Susan, can you comment on that? Because we clearly, typically, the standard is the FISH for deletion 17p, but we probably capture more mutation by NGS, right?
So I think, are we talking about getting prognostic panel at a patient at the time of presentation?
At diagnosis, yeah.
Yeah, well, again, you could argue if the patient has very little disease and you're going to watch them, do you really have to get any of the prognostic factors, right? We know where we really need them is when we're going to start treatment. Because, again, the point is if there's a 17p deletion, then that patient should never get chemo. So we know we need them at the start of treatment, but if it's a watch and wait patient, would you get them up front? Generally, I do, because, and Lori had touched on this and I touched on it previously, which is then I use those prognostic factors to figure out how frequently to follow the patient. If they're relatively high risk, I'm going to follow them more frequently. So it doesn't change what I do. If they're really an asymptomatic patient with not a lot of disease, irrespective of their molecular factors or their chromosomal factors, I'm not going to treat them. But it may impact my follow-up durations.
We have a question now on duration of treatment, several questions on duration of treatment. One of them is that, when can I stop ibrutinib, and can imaging help me decide to stop ibrutinib? Lori.
So in general, it's obviously taken case by case, but in general, ibrutinib is an indefinite treatment, as are all the BTKs, unless you have an unacceptable side effect or you start progressing, so it stops working. There are some clinical trials that we are using something called minimal residual disease, or MRD, to try to maybe add something to the BTK inhibitor and eradicate every detectable cell and potentially stop treatment. But that is a research question. And of standard of care, certainly in most practices, if not all practices I'm aware of, would not be something to do based on imaging or routine blood work. Minimal residual disease is something we typically check, and I think we'll talk about in a minute at more academic or subspecialized centers, but it's not an easy to do test, so it's not something most general oncology practices have access to at this or follow at this time point for CLL. But in general, ibrutinib and BTK inhibitors should be considered indefinite as long as you can stay on them.
Yeah, I would agree with that, although sometimes when I'm starting a patient, if they're really, really bothered by that thought of, oh my gosh, now I'm going to be on this drug forever, what I have told them is, look, patients who get it, particularly if they get it as their initial therapy, they get really good remissions, even if they don't get a complete remission, complete meaning we can't find any evidence of the disease. They come close. So they're really good remissions. Their lymph nodes go away for the most part. Their blood counts are normal. And what I tell them is, look, if in a few years, not a few months, because if you stop in a few months, the disease is just going to come roaring back. But if in a couple of years, you're in remission, you feel great, you want to get off the drug for whatever reason, I don't think you're going to be cured. I think the disease will come back if you get off, but I suspect it will take a while. You know, if they've had a good, let's say, 3-year remission, they're not going to relapse next month. They're going to relapse potentially months to years down the line. And so I will tell that to the patient. We can sit down and have a conversation at that point so that there might be some prospect, if it's really important to them in their minds, for the possibility of discontinuation. Now, have I gotten to the point where that's happened? No, because none of my frontline patients on ibrutinib have gotten out really beyond at 3 years. And I'm picking 3 years kind of arbitrarily, but I actually, the patients I've started where I've told that to, you know, if it's really important to you, we can have a conversation, not in a few months, maybe in 2 or 3 years. That hasn't actually come up where a patient has said, okay, I'm doing great, I've been on it 3 years, can I stop? But I think giving them that hope that maybe I don't have to be on this for the next 10 or 20 years is reasonable.
And I hope in a few years that we'll have a way to take everybody off indefinite therapy. The way how rapidly things are changing, I think that that's possible. So I think that that's a great point, that we should obviously always give our patients that hope that even though we discuss something now, even in a few months, we could have different information and very much change that recommendation.
Things are changing fast. One question on the role of the antibodies. You know, we talk about at least BTKs, and then it's very common in lymphoma, including CLL, that we use that in combination with an anti-CD20 antibody, rituximab or inotuzumab Gazyva for CLL. So what is your, Susan, can you comment on what's the benefit of adding an antibody in a frontline setting when you combine with a BTK inhibitor?
I think it's not clear. So we have, let me back up. With rituximab combined with ibrutinib, that did not seem to provide any benefit over rituximab alone. In the acalabrutinib trial, the antibody
over ibrutinib alone.
Right, no difference in outcome. Okay, sorry. In the acalabrutinib trial, that they used a different antibody, right? They didn't use rituximab; they used obinutuzumab or Gazyva, as the commercial name is. And what we saw when that data was presented just this year is that the acalabrutinib and Gazyva curve, in terms of how long people stay in remission, looks a little bit better, maybe, but it's not what we call statistically significant. In other words, you could get that much difference in the curves just by chance. So with longer follow-up, it may become clearer if the antibody really adds anything to acalabrutinib, and why would it add to one type of BTK inhibitor, not the other? Maybe because it's a different antibody. I don't know. With venetoclax, I think the data, you do have to give it with obinutuzumab in the frontline setting. So there you definitely need the antibody. I think with the acalabrutinib, it's not clear. The way it's actually been approved is that the physician can choose whether to give it with the antibody obinutuzumab or not. It's actually up to the physician. So if you're a patient and your physician's discussing it with them, that would be important question with you. That would be an important question to ask them. Well, are we going to give it with antibody or just alone?
Andrew, you want to add any comment on your perception on the antibody?
Yeah. I'll just comment mainly because I agree with the CD20 antibody discussion Susan just mentioned, but at our site we've been doing a trial looking at a different antibody called serumtuzumab, which came out of San Diego, but it's a ROR1 antibody. And it seems to be synergistic with ibrutinib or BTK inhibitors. BTK inhibitors, ibrutinib and acalabrutinib, they basically work in one route of the leukemia or CLL cell from growing and growing and growing, but eventually, that route might be circumvented by another way the cancer cell survives, and so you need potentially a second therapy to keep a longer remission, and that's basically what this newer antibody is trying to do as a combination therapy. And we have seen already some initial promising preliminary results reported last year in early phase trials, and we're continuing to enroll patients here at Hackensack. So I think there's a lot of questions also in the chat, I think, regarding stopping or continuing ibrutinib, but it's just unclear right now, and I think we'll know in the future, hopefully, with some of these trials, as everyone's mentioned.
So there are many trials that are ongoing and still in the frontline setting to look at durations, MRD impact, and all that, but without going necessarily into super detail, I think MRD is going to be obviously a big part of managing CLL, particularly when you use a BCL2 inhibitor, venetoclax, and as part of the limited duration therapy. So one of the questions that comes is that, have you seen patients that can still achieve MRD when you have to reduce the dose of venetoclax, for example, or a combination of ibrutinib and venetoclax? Have you still seen patients achieving a CR and obviously MRD negativity, and do this have the still behavior, still outcome? Susan.
Well, we remember when we talk about MRD, we're generally talking about a test to look for 1 in 10,000 cells. So it's a much more sensitive test than just looking at a bone marrow exam and saying, oh, well, there's no disease there, right? Because the bone marrow exam is a tiny piece of the bone marrow. There's a ton of bone marrow in the patient's whole body, right? So one can imagine that, that's a good sign if there's no disease, but that's a very gross estimation of disease. So now with these MRD assays that we generally are talking about, the standard ones can detect 1 in about 10,000 cells, and there's some newer techniques where you may even be able to detect lower levels. That level of response is almost never seen with a BTK inhibitor, or very rarely. So meaning ibrutinib or acalabrutinib. Where it is seen is with venetoclax therapies. And there is some data emerging, not a lot, because of all those 3 drugs we're talking about, that's the newest one, acalabrutinib is as new, but the initial treatment data both are very new. That if you do have to lower the dose, that patients can still do quite well. But I think that's very early data with venetoclax-based therapies, and we still need longer follow-up on that. But there doesn't seem to be, with the follow-up that we have, a big problem if you have to lower the dose because of the side effect and still continue the patient on venetoclax. That's true for ibrutinib, but that's not based on MRD. So in other words, there is data that if a patient with ibrutinib needs a dose reduction, well, if we're not measuring MRD, how do we know it's not impacting them? We look at the length of their remission, right? And data suggests that even if you have to lower the dose of ibrutinib, those remissions are still very, very long. So dose reduction seems to be possible with all of these drugs and still have reasonably good outcomes.
There's several questions that I'll do to this, and that sort of touches up, and leads us to the relapse setting and after progression of CLL. So is these novel agents that we use more and more in the frontline setting, how do they fit and how do we use them in a relapse setting? So I know this is a broad question, but if you can give some pretty high view guidelines or high view, Lori, maybe?
Yeah, so for me, usually one of the most important things about second line setting is what did the patient already get? So if a patient got chemoimmunotherapy, I'd want to know how long was their remission, what are their comorbidities, and then would have a similar discussion with different options. Any of the BTK, acalabrutinib, ibrutinib, or venetoclax, all approved approaches in the relapsed refractory setting. I think, too, the other thing I look at is their prognostic and predictive factors and age. So if I have a young patient who had a targeted therapy, whether maybe a BTK inhibitor, and is relapsing, we do have other choices, but that's someone I would think longer term, I should screen for clinical trials, and also may need something like an allogeneic stem cell transplant in the future, which is not used as commonly now as it used to be in CLL, though still in a very young, poor prognostic future patient may potentially play a role in the future and does take some coordination, so needs to be thought about in advance.
Thank you, Susan. In a relapse setting, I mean, sort of a high view as well. I know it's a broad question. How do you use those novel agents?
Right. So I think that's changing. So what happened initially is ibrutinib has been around a lot longer than any of the other drugs, right? We now recently saw the published data for 8 years of follow-up. Of course, that's clinical trial data, but ibrutinib was the first drug approved, and it's been around a long time. So what happened is, generally, at least in the United States, where we started using venetoclax was in people where ibrutinib stopped working. So there was plenty of data that emerged that venetoclax worked quite well in that population, even if their disease was resistant to ibrutinib. Then when venetoclax was approved, the question became, well, if you use venetoclax first, say with Gazyva as frontline therapy, will a patient respond to ibrutinib after that? And up until maybe within the past year, there was very little data to know. So I think that tended to push people to use ibrutinib first, knowing that they could have venetoclax in their back pocket and it would work if the ibrutinib stopped working. Whereas because venetoclax was so new and most people were still responding to the drug, we didn't know if going from venetoclax to ibrutinib would be effective. But we did see last year in some presentations at American Society of Hematology now that there were patients who got venetoclax first, like now we have it as a frontline therapy option, and then went on to get ibrutinib and actually responded quite well. So now I think that concern for, well, is it better to go one way than the other? I think that concern has been alleviated, and that's impacting less the choice. And really the choice now is more the side effect profile, the limited duration versus continuous therapy, the kind of things we talked about early on in the start of our meeting tonight.
Thank you. Andrew, in a relapse setting, when you see patients, sometimes patients with CLL, when they relapse, we know that they can relapse several times over time, and a small fraction of them can have a more aggressive lymphoma, the transformation. Can you maybe tell our audience a little bit about this transformation and how we treat it and what happened in those patients?
Yeah, so basically in a small percentage of CLL, SLL patients, when it's typically, smaller cells on the pathology, they can become bigger, larger cells, and we call that large cell transformation. And commonly it's referred to as something called Richter Syndrome. And usually this is a much more aggressive lymphoma that can progress within weeks to months and lead to organ failure and a bad outcome for the patient. And so for those patients, we don't typically think about just ibrutinib alone or acalabrutinib alone, but actually intensive chemotherapy, intensive combination chemotherapy, such as rituximab and an R-CHOP type regimen. And at Hackensack, we use something specifically like hyper-CVAD or EPOC or something like that. But basically, it's an intense chemotherapy regimen that typically is given every 3 weeks for up to 6 rounds. And those patients you might also consider afterwards, if they relapse, you might also consider allogeneic stem cell transplant in their future because it is a sign of a very aggressive disease.
And I'm sorry if I missed it, but and there are some data where we can start to combine some of these agents like venetoclax with chemotherapy in a setting or immunotherapy as well. Laurie, how do you manage a patient who rarely that has transformed with the question that came twice tonight?
Yeah, so I think we see it more commonly in the higher risk CLL patients, 17p unmutated. And it's important to me whether it's an event that happened in someone who is on watch and wait, someone who's been on targeted therapy for their CLL, someone who previously had chemotherapy for CLL, or I have a number of patients that were diagnosed with CLL presenting as Richter transformation at the same time. So if a patient's never been treated before and has Richter transformation, I do try to address both the CLL, or at least consider, and the Richter even though they're related to each other at the same time, and try to add some of the targeted therapy or add target therapy potentially to chemotherapy. We do have data looking at adding ibrutinib to something like R-CHOP, safety-wise tolerated. I think we have, we also have data looking at adding something like venetoclax to an R-CHOP-like regimen that's being studied to see if maybe that's a better approach in Richter. To me, the problem or the challenge with Richter is that it's relatively rare. So there aren't many studies that have a large number of Richter transformation patients. And when patients come in, they're usually relatively sick that they can't wait a long time to start treatment. So I think in the relapse setting, some studies are ongoing in this general area about looking at immune checkpoint inhibitors in combination with BTK or PI3 kinase or other targeted therapies. But in general, there's not much data to guide us in Richter.
Thank you. Suzanne, there's two questions that alluded to the risk of infection over time. Two patients that seem to be concerned and that you take a drug that is a suppressor of B cells over time, and one patient mentioned having more upper respiratory infection. I don't know more detail about antibodies on this patient and all that, but can you comment on the risk of infection over time when you take this medication and how you manage that?
Yeah, so we know that patients with CLL are at higher risk for infection just because their immune suppression from their disease. So when you start a BTK inhibitor like ibrutinib or acalabrutinib, you do suppress normal B cells, but there is some data to suggest that you improve the function of normal T cells. And T cells are also a very important component of fighting infection. So there's some data to suggest you may be less likely to get infection on these drugs, but also keep in mind that if you're on the drug and your disease is responding, that's probably the biggest reason that you're at reduced risk for infection on most of these drugs. Venetoclax is a little bit different because venetoclax can cause neutropenia, where the neutrophils go quite low, and neutrophils are also very important in fighting for infection. So what do we do about that? We have to monitor the blood counts periodically. There's two ways that could be addressed to try and prevent infection. One is using growth factor support, a shot like G-CSF that can be given that stimulates the bone marrow to make neutrophils. But if it keeps becoming a recurrent problem, then generally the way to address it is to reduce the dose of venetoclax. If you don't have much neutropenia with venetoclax, you really are probably not at a significantly higher risk for infection. So I think certainly vis-a-vis chemo, the risks of infection are not gone, but they're never going to be gone in a patient who has CLL and has disease, because that is probably the biggest component contributing to the likelihood of infection and not necessarily the treatment.
Can we talk by extension about this, sort of the recovery of the immune system when their disease goes away on long-term on BTK inhibitor, for example? How do the immune system get better over time afterwards? Suzanne?
Well, I mentioned the T cells getting better, but interestingly, another aspect of patients with CLL is sometimes they have low gamma globulin levels. Now, we don't replace gamma globulin routinely because it would have to be given every month and it's very expensive. But in some patients with recurrent sinus or pulmonary infections, if we give them gamma globulin, it can make a big difference. One thing is that, well, will the gamma globulin levels necessarily get better with these drugs? And interestingly, I'd say there's very little data that I've seen so far to know with venetoclax, but we do know with ibrutinib, sometimes they get better and sometimes they don't. So even though the patient could be having a great response of their disease, the globulin levels may stay very low. So that is something that can persist and potentially contribute to infection.
And two, I think we know that patients that at baseline have a slightly weakened immune system for whatever the reason, maybe do have an increased incidence of lymphomas, including other lymphoid malignancies like CLL. So maybe it could be the patient's underlying immune system that wasn't checked, prior to the CLL diagnosis or treatment. Also that we're seeing with the more prolonged hypogammaglobulinemia or whatever other type of immune suppression after treatment's complete.
So we know that patients do really well with all this novel therapy. It's one of the big questions is obviously that remains, you alluded to, Susan, to somewhat, is that what's the best sequence of treatment? But we know that unfortunately there's still a fraction of patients progress, and we cannot actually talk about CLL without talking about emerging novel therapy and maybe a minute on CAR T cells. And CAR T cells is potentially something that could, obviously is approved in aggressive lymphoma and ALL and acute lymphoblastic leukemia. And then there are lots of promising data. So maybe, Laura, you want to start on this, on the CAR T in CLL maybe?
Sure. So CAR T cell or chimeric antigen receptor T cell therapy is when you take a patient's T cells and engineer them to recognize something on the outside of the cancer cell, usually, and what we'll be talking about is a protein called CD19. And then you infuse the cells back and they act as kind of a cancer-fighting army. So as you mentioned, Andre, very successful and approved since 2017 in aggressive lymphoma, diffuse large B-cell lymphoma, also approved in certain types of acute leukemia. Lots of promising data coming out in mantle cell lymphoma. Just recently, some published data in another type of indolent lymphoma, follicular lymphoma. And the studies are ongoing in CLL, many different constructs. I think it's been a little more challenging in CLL, the development. Something about the CLL cells may kind of impair or affect how those CAR T cells grow and expand and turn into the cancer-fighting army once they're infused. So that's being worked out. Early evidence suggests maybe things like ibrutinib may alter the immune system in a way that makes CAR T cells more effective. So maybe in combination or using before you collect the cells, those are things we're looking at. So it's a very active area of research, but certainly a little further behind than the other approved or probably soon to be approved indications throughout lymphomas.
And to wrap up a little bit, I think we talked about we are still in the era of COVID, obviously, and many of our patients and colleagues online here, patients in the audience are on BTK inhibitor or CLL patients. And one of the questions is that does it affect their risk of disease with the COVID-19? So, Andrew, you want to comment if a patient is on a BTK inhibitor, maybe?
Yeah, I'll comment on that, and also for those exposed to rituximab or CD20 antibody therapy. So it seems like there are some initial case reports, case series that BTK inhibitors are beneficial for patients, for CLL patients who are on that current therapy and were infected with COVID compared to a similar CLL patient who was not on BTK inhibitors. And that was an interesting finding published a month or so ago. And there are current studies looking at, I believe, acalabrutinib and its use in severe COVID-19, including, I believe, Andre, you treated several patients as well. But so there is ongoing investigation as to BTK inhibitors as not only as a CLL cancer drug, but also as a COVID-19 drug. And then I was just going to mention for patients given rituximab or blinatumomab, there's ongoing investigation or questions as to whether or not they can produce potentially adequate antibodies after they've been exposed to COVID, and we don't yet know the answer to that question. So we're actively looking into that. So.
There's two questions that just came about the risk of other cancers when you have a CLL. Thank you, Andrew. Risk of a CLL and what is the connection between melanoma and CLL or other cancers and CLL? So, Susan, maybe you want to give us your take on that?
So we know that patients with CLL do have a slightly higher incidence of second cancers in addition to the CLL. The one that's particularly associated with are skin cancers, but not melanoma, rather the squamous cell carcinomas or the basal cell carcinomas that people get in sun-exposed areas. Those go up very significantly in patients with CLL. In terms of any other one cancer, no, it can really be anything. So what do we do about this? Basically, what I tell my patients is you just need to do the same screening at the appropriate age points that anybody else would do. So women, right, mammograms, pap smears, and people beyond a certain age, colonoscopies. You have to do all of that standard screening, and I point out to them, and particularly if they have a lot of actinic changes or sun exposure or sun damage, I have my patients do dermatologic exams at least once a year, where the dermatologist takes a really good look at them. And particularly relevant if you live someplace like California, or Florida, where a lot of patients have sun damage over the years. So it's really regular routine screening. Plus I add on the dermatologist, certainly here in California, because I see a lot of skin damage from sun. And if you stick to the standard screening, hopefully, no smoking, obviously, will reduce your risk for lung cancer. All of the normal things we should all be doing, maybe with the addition of the dermatologist, which not everybody needs to do, and avoiding further sun exposure. I think those are the key things that I tell my patients. Thank you.
Lori, question on the CLL risk factors in a family. If someone has a diagnosis of CLL or lymphoma, what is the risk of the sibling? It's a frequent question we get in the clinic.
Yeah, so we haven't identified a certain kind of genetic test that we can do for lymphomas and CLL like we have in breast cancer. But even, patients in general that have cancer, I think it was Johns Hopkins that did a big study in looking at even the cancers that we know there are potential genetic links. Majority of cancers are spontaneous as far as we know. So I think that just shows we probably don't understand. We have several families that have several patients with CLL or lymphoma, and the question becomes, is it something maybe in the environment, where did they all grow up in a certain house or area that had exposure to the same thing? Or is it something with their genetics, something about their baseline immune system that makes them more prone to develop lymphoid or immune system cancers like lymphomas and CLL? My opinion is it's probably a combination of both. However, if I have a patient with, CLL, in fact, one I saw today, a patient with CLL and a family member has a low-grade lymphoma, a sibling, and they want to know, what should we have our children screened for? I say that's why your doctors usually take your family history. They want to know what trends there, and do the, as Susan was just saying, usual age-appropriate cancer screening, but there's no specific, genetic counseling type test that we can do to determine if that person's at increased risk for CLL or lymphoma or not.
One more question now on Susan, on the vaccine and CLL. So the patient with CLL get a pneumonia vaccine and a flu shot.
So yes, but here's what I tell my patients. There's no downside to getting it, but we know that patients with CLL don't always have a good response to the vaccine. What do I mean by that? I mean, what is a vaccine doing? It's trying to boost the patient's own immune system, right? So if the patient then gets exposed to the flu, for example, their immune system revs up more quickly and can knock it back more quickly. So it is dependent on their own immune system. So in patients with CLL, we know that many of them, and unfortunately there's no simple test to know who's going to respond better to a vaccine or not. But we know that some people are not going to respond very well. So I say, you should get it because there's no downside and it may help protect you, but don't be too bold, because you can, first of all, even in people who don't have leukemia, vaccines are not 100% effective all the time. There can be a subtype of the flu that vaccine doesn't work well against. I also tell them what's really important, and maybe even more important than you getting the vaccine, is your spouse or significant other getting the vaccine. Because if you're going to get sick, who's the most likely person you're going to get it from? Well, the significant other who lives, or somebody who lives in the house with you. So I tell them, get the vaccine. Again, I can't tell you if you'll have a good response or not. Hopefully you will, but it's very important that anybody you live with has to get vaccinated to protect you.
Thank you. I think we have answered a lot of questions, and I think we are sort of running out of time. And if you'd like to watch this webinar on demand, it will be available on curetoday.com/webinars, curetoday.com/webinars within the coming days. I want to thank our panelists for an exceptional work tonight and sharing their perspective on CLL and all the exciting developments. And you, the audience, for attending and participating in today's event with many questions. We answered all the ones we could answer as part of our discussion here tonight. And I would also like to thank you and our sponsors, Janssen and Pharmaceuticals, for making today's educational webcast possible. Don't forget to check your email tomorrow for the survey to be entered to win a gift card. And thank you all for joining. We'll see you next time. Have a great evening. Thank you very much and be safe. Good night.
Thank you.
Bye.
Thank you.
Good night.
Bye-bye.
Bye-bye. Thank you. Thank you.
Bye.